Hi, I'd like to welcome everybody to this next session called Where Can I Find Reliable Information? I'm going to be joined today by Nikki Lyons, who I first met actually through the Coalition Against Childhood Cancer, where she presented a similar presentation, and I thought it was amazing, and we wanted to bring this here to everyone today. We're going to start off today, though, and I'm going to begin with a little discussion about the differences between little a and big A advocacy. So if we could go ahead, there it is. Wonderful. All right. So a lot of us use this word advocacy, and when we're going to try to decide how to go about using reliable information to make a difference, either for the child that's in front of us or the systemic challenge of childhood cancer, we really need reliable information in both of those situations. But before Nikki talks about where to get those wonderful pieces of information, I'm going to talk a little bit about the difference between these little a and big A advocacy. Next slide. Great. So imagine a world, and unfortunately, many of us here have not had to imagine this world, but where your child or yourself, you're diagnosed with a pediatric renal cancer or other cancer, and you don't know what questions to ask. You don't know where to turn. You're not sure where to get reliable information about that. Now imagine this other world, the one that is in the exact same moment. You are instead equipped to be able to speak up. You know what to ask. You know how to push for what your child needs. That difference is advocacy. Next slide. So now imagine a different world, the one in which those individual voices don't stay isolated. And instead of focusing on that primary need of advocating for the child or for yourself in a medical situation, you now begin to understand that some of the problems you've been facing are things that other people are facing as well. So those voices, instead of staying isolated, come together, inform research, change and shape policy, and change what's possible for the next child. So that difference is also advocacy. And I just wanted to show some pictures here, some great examples of advocacy that have happened in the last year or so. We can see a picture of myself with several of the moderators from today in that upper left-hand corner. And that group of amazing and powerful moms came and joined us to work with clinicians, many of whom are in these sessions today, like Dr. Elizabeth Mullen and Dr. Cost, who we just heard from, and talked about what kind of changes we want to see for the next 1 to 3 years for treatments and care. And it was just a really beautiful collaborative session. That's change for the systemic good, change for the next child. You'll also see some other examples here where we've attended events with other nonprofits where we advocate for children in clinical trials, or you'll see Kelly Trout and Andy Hong in that picture there at an event that we hosted where, again, advocacy and clinicians coming together, and a family in the lower right-hand corner there advocating for state funding for pediatric cancer. So next slide. Excellent. So advocacy is central to our work at Elevate and I think also with KCA. And we have 3 pillars: advocacy, empowerment, and strategic investment. And advocacy can be what we refer to as little a advocacy, or advocate, which is advocating for self or a loved one, or it can be that big A advocacy, changing the system that we have available to us. Next slide. I wanted to walk through just a little bit some examples about little a advocacy, and I think in a little bit, Nikki's really going to jump into this more. These are the everyday actions that individuals and families take to understand, navigate, and improve their own care. There's a list of those things down there. These are things as basic as speaking up when something doesn't feel right, being able to say, I don't understand what was just explained to me, clarifying treatment options, seeking that second opinion. These things are all just part of that little a advocacy. Next slide. All right, these are some key characteristics of little a advocacy: that individual or family focused. A lot of times they happen in real time. And as a fellow cancer mom, I can tell you, under stress. This is usually something that's happening under stress, and it may be invisible to others, but it does take up an enormous amount of our energy and time when our children or ourselves are going through a diagnosis. Next slide. Okay. Being able to advocate in this way requires confidence and access to reliable information. And so again, you're going to hear more about where to find that reliable information. But I will say that part of the reason we're hosting this event today is because KCA and Elevate are dedicated to making sure that you guys have access to high quality information. You get to hear directly from the scientists and clinicians doing the work. Next slide. Excellent. So big A advocacy. We're going to have a session, a drop-in session later today about what this is. This is collective public action aimed at improving systems. So this is what happens when you start to notice that the little things that you're experiencing are things that you want to change for the bigger system. And so that could be advocating for federal or state research, shaping studies, priorities. I'm not going to go through this whole list. You can read it. But you'll see here that there's just a lot of places where big A advocacy can take place. Next slide. Some of those key characteristics. It's long term. This is the long game. It needs to happen collaboratively and collectively. And we're really aiming to change the system, not just the individual outcome. Little A advocacy is so important. You're driven to make a difference for your child, and that's what is really, really important. And then at some point, if you're doing big A advocacy, it's about changing the entire system for every child who comes after. Next slide. Okay, this is just an example. This is really overwhelming when we really start to think about the number of different stakeholders that are involved in what's happening in affecting change, the system around our kids. So we see people that are really getting involved in advocacy with, the clinician or with program managers or maybe policymakers like the FDA or legislators. And there's also people who may be engaging pharmaceutical companies or the general public so they become aware. So there's a lot of stakeholders involved. We believe that advocacy is at the center and that we really want to make sure that our children are the focus of that. You'll notice that we have a process that we use to do that, but our goal is that we co-produce solutions with these different stakeholders. Next slide. And again, advocacy relies on credibility, influence, translation, and collaboration. Next slide. So this is really important. Understanding what the stakeholder is going to respond to is really important when we're advocating. So I've put CAC2, the Coalition Against Childhood Cancer's logo here because really they're an umbrella organization that gives us access to high quality information about what's happening. So I wanted to highlight CAC2 in this moment. It's a great place and way to get involved. I know we're members of CAC2, but when we think about policymakers and researchers and clinicians, they're going to respond really well to data, patterns, and evidence. And while our personal stories open the door, this other information really provides this weight to it. Again, without reliable information, misinformation can spread. So it's really important that we dig into those reliable sources of data when we're advocating. Next slide. So influence. In order to change systems, we have to identify the real gaps and propose viable solutions. And I know so many of you are out there wanting to be able to make those differences. And again, how do we make sure that we're approaching this from a perspective that those that we're trying to affect change with can hear us? Go ahead and do the next slide, please. And then we want to translate our lived experiences into language that decision makers can understand. And again, many of us, not everybody feels compelled to do this, and that's completely okay. But after going through this childhood cancer experience, some people are going to feel like there can be meaning really in affecting change for the whole system. We wouldn't want everybody here to feel like, oh, you have to do that. But at the same time, if you want to, we want to make sure that you know that the door is open and we're here as an umbrella helping to do that. Next slide. And finally, collaboration is key to impacting real change for all children and young people. There are just not enough of us. While we know that there are way too many kids affected by this, there's still so many people spread out in so many places, and we really want to pull everybody together as much as possible. Each form of childhood cancer needs to have its own voice. So Wilms tumor needs a voice, and all these different types of cancer need a voice. And yet at the same time, there's also these great umbrella opportunities to make a difference. So places to get involved, Pediatric Inclusion Alliance, the Elevate Wilms Work Group, hospital parent boards, and more. State cancer plans, CAC2. And again, we'll be hosting a session later today. Last slide. Talking a little bit more about how you can get involved if you want to. So now I'm going to toss it over to Nikki, and she's going to talk a whole lot more about what it looks like to dig into reliable information for patient advocacy. Thanks, Nikki.
So I'm mostly going to talk about how to not just get information, but also see the relevance of it and how to go through it. So I always tell all the patients I work with. So for background, I've worked as a researcher in pediatric cancer for about 10 years. So I've learned a lot of biology, and most people don't want to learn as much biology as I chose to. And you learn more new words your first year of biology than you do learning a new language. So it's a lot. It's new context, it's new terms about the cells, but it's also new terms about how studies work. So for the next slide. So the example I use, and I'm not saying which drug or which type of cancer, but this is a real example. There was a New York Times article that was talking about this drug that came out and that was being repurposed, and this might be a cure for an incurable cancer. And I had a lot of parents email me being like, how come none of our doctors are talking about this? What's going on? Are things being hidden? And that sows a lot of mistrust. So for next slide, so when you see something like a Wall Street Journal or New York Times talking about a scientific article, and usually that's the first place you're going to see it because you type it into Google, is looking at who wrote it, where is it published? Is it a peer-reviewed journal? Those are the ones you'll see on Google Scholar or PubMed, and they have boring names like Just Science or Cell. Do you see a .gov, a .edu? And you want to look at what the goal of these articles are. So if you see something from a newspaper, they're going to be a bit more about catching attention rather than dryly stating data. You want to see if things are cited. And there's some red flags that I always look for when I'm looking at information. Are these claims a little too certain? Is it saying, are there terms being used that are like every single time, never this happens? Almost too good to be true. It kind of sounds a little bit like an advertisement. So next slide. So going through something like this, and again, it was a real study, but you dig in a little bit more. It was a case study. They didn't talk about the very specific mutation this child had. So it was a reputable source, but not a scientific source. So it's going to be talking more about, there's going to be more narrative, less science to it. And what's the goal? If it's presented really exciting, the goal is to be exciting. It cites information from a credentialed data, but there's only so much you can do once you realize it's a case study. And that gets very tricky to have to sort through all that types of information. So next slide. So I put together these checklists to look for something like, is it a case study? That means something's atypical. That's really hard to apply to a bigger group of people, but it might be really applicable to someone who has the same mutation or someone else who's in a specific situation. So I use this as my first example because this is something that it's very directly related to a patient, but it's hard to apply to a bigger group of people. And it's a good example of where you need the context of information, not just is information coming from a source that we trust. Okay, so next slide. So I adapted this from what I use when I've taught undergrads how to read a scientific article. And this works for anything from like some big, giant, long study to just an abstract or a summary, is you want to think about what was studied and how was it measured. So I'm sure everyone's read articles and they've talked about things that are different. Are they talking about cell growth? Are they talking about stopping progression? Are they talking about tumor cells dying off? These are different things that are studied in different ways. We want to look at, are you looking at adults? Are you looking at kids? Are you looking at just cells or mice? Is this a clinical trial? Because they all tell us different things. And then also looking at how, again, going back to the case study example, is how many subjects were there. So the nice thing with cells is we can get millions and millions and millions of data points really quick, but they're a bit less relevant to humans because they're in a dish. So next slide. And then we also think about this outcome that was measured. So especially in clinical trials, you have these outcome measures, and sometimes they're just looking at something that's about as black and white as an MRI. And that's not as helpful for thinking about things like quality of life and symptom management and things that are a bit more subjective, but there's lots of studies that also keep that as part of their measurements. Has this been repeated? You know, if something is standing out and very different from everything else that has been seen, that might not be super reliable, but there's always a healthy amount of debate between all scientists. It's really hard to get them all in a room together to agree on things. And then one of the biggest green flags that I have when I'm reading research is, do they mention what we don't know yet? I think it's really important for doctors and scientists to be very well aware of what we don't know and what questions we can't answer rather than trying to poorly answer a question. You know, we only know so much and we're trying and learning. And I think that that is a big transparency thing. That's a really big green flag for studies. So next slide. So I have a list of places to find reliable sources. This is on the website. So I'm not going to go through all of these. So next slide. Next slide. So it's a mix of things from the NIH. It's about clinical trials. It's every amount of in-depth you want to go into a bit of information I could think of that are reliable. It's sources I've used. So it's a little bit about how outcomes are measured. So these are words that you would see reading through things. So the differences between, so if you're asking a question that's like, did a treatment work? Rather, that's not going to be always a yes or a no. So you could have complete response, which is there's no tumor you can see. A partial response is it's starting to shrink, or a stable disease where something didn't grow. So in cancer research, these are all positives. These are all something that is, yes, it's working. And it's confusing at first to see something where it's just, okay, all I did was pause the tumor. That is still something that's helpful. And that's something that I don't think is always explained when doctors start to talk about how a study is going. And then the next question would be, how long did something work for? So that's where we have something like an overall survival, an event-free or progression-free survival. So talking about how long someone would be on a study before maybe they start having adverse events like a seizure. Because that's also important, because just knowing how long someone stays on a trial doesn't, again, address quality of life as much. So next measure, or next slide. So again, going back to the example of context. So I study inflammation. So this is what I'm partial to, is you read a lot of things that are like anti-inflammatories and inflammation is really bad. And it's always talked about very negatively, but it's actually really important for your immune system to have some level of inflammation to be able to start fighting things. Like we talk about how you don't want to, like a fever is your body working to fight something if you have a cold. But it can be bad in different contexts. And same thing with like natural supplements, is you have things that are natural, you think of them as safe and healthy. And then, for example, like I've had kidney disease for the past 10 years, and there's a lot of things that are natural, but because of my kidney disease, can't have them. And that's one of those things where the way things are spoken about in the context and these connotations of words are important to be aware of, and also understanding that it's important to talk to your doctor about something that even if it feels really benign. Okay, next slide. So the reason we use cell lines, animal models, and human trials to answer the same question, as I like to think about it, is you're trying to get a picture of something. And each of these things are a way we get some part of the picture. So if you want a good picture, you want it to be in focus, you want it to have color, and you want to be able to make out the shape of what you're seeing. And three-dimensional, that's what I use. So if we look at cells, we can learn a lot about them because we have lots of numbers and we have a lot of control over it, but it doesn't have the environment that is around the body. So it's not in an organ, it doesn't have the vasculature, it doesn't have the immune system. So I always think about it as like a two-dimensional drawing. And then animal models, you lose a little bit of the control and you have a bit more context because it's in a body. So now you have a 3D picture, but there's no colors and it's a little bit less in focus. The next slide. And then when you get to clinical trials, it's the thing you want to be looking at. It's people. There's 3 dimension, it's in color, but it's a little out of focus because you lose a bit of control. So that's where we have all these pieces to put it together and have the best picture of what's going on that we can see. And that's why you have everything gets repeated and you have to be very, very sure to take things to the next step for science. And it always feels like things are moving way too slow, and they are. But there's a lot of steps that are also really, really important for us to take. The next slide. So this is what I call my little flow of knowledge. So this is when you're looking at trying to answer a question, you want to see, is there an impact? So first, just yes or no, is something doing something different? Then you look at what this impact is. Then you start to look at, okay, is it moving towards or away from my goal? So one of the things you get taught early in science is negative results or still results. You always want to know, like, if something doesn't work, you don't want to repeat. You don't want to keep trying to reinvent the wheel if the wheel's not work. And then you start looking at, are these impacts sustainable? Why does it happen? And then you start to try and figure out how you can influence or control that impact. So that's where you want to look at a medication, like, is it doing something? And then down the line, you start trying to look at, okay, like, how do we use this in the exact best way possible? How do we combine it with a different therapy? So it's really important to be able to look at that whole scope of things. So that's where there is research you'll see that feels very far from humans, but it's still really important to find that first bit of impact. Okay, next slide. And then I always give everyone this example of if you type something in the chat GPT, because I know that's a very helpful way sometimes to try and get through these really dense articles. So again, just asking if something works is not the best way to ask a question. It's the same thing kind of talking to your doctors too. And so I have a few examples of just how to better ask questions. So rather than saying, did this work? What kind of cancer did it work for? How was it given? Was it a mouse? Was it a mouse that had an immune system? How similar would that be to a real patient? Are we seeing something works again? Is it stopping a tumor? Is it killing a tumor? Are there side effects? There's lots of studies I'll read that'll be like, these mice have no evidence of tumors, and then it's the mice also aren't having a good time. So it's important to have good context with that. Right, next slide. And this is just an example of better options. So like, what kind of model was used in the study, and then ask to explain what the model is. Like, I could think of 6, like I work in brain tumors, and I could think of 6 different ways you can make a tumor in a mouse, and there's goods and bads to all of it. And the next slide. Again, these are just questions like immunotherapy, how does that work with cancer? Why is research so slow? Which would be a big answer. And the next slide, I think. So this is just my little spiel, like this is how we avoid having the same conversation, like a doctor having the same conversation, a researcher having a conversation, and patients, and we're all trying to say the same thing and no one realizes it because we all learn different ways to talk about the same thing. And so this is kind of my, as a scientist, guide to help someone who isn't a scientist learn how to speak the language a little bit, so you can better ask your doctors questions and better communicate with them. And they don't always and doctors are really doing their best to try and learn how to talk to patients. But it's difficult when you've never been a patient. And then partnership between everyone really creates better research and better patient care. I've worked as a patient advocate the whole time I've worked in research, and it makes a really, really big difference. Like, even things I'll try in the lab, I'll be like, oh, this would make sense in cells, but I'm like, this isn't realistic for a person. Like this would be not helpful. And And everything I've learned from parents has made a huge difference for me as a researcher. And I know a lot of the people, a lot of the doctors I work with feel the same. And then the next few slides, I gave an example. So when I was on dialysis, going through information that I had to find for myself. So if you want to go to the next slide. Next slide after that. Yes. So when I was on dialysis, was not supposed to have pain from it, but I did. My doctor was like, this doesn't make sense medically. Why is this happening? That was a time that it was really helpful for me to go and find patient forums. Like I went on Reddit and just was like, are other people feeling this? Is this something that's happening? And other people were like, yes, it's that. I'm like, okay, so this could be from dialysis. And I was thinking like, okay, I know where on my body my dialysis catheter is. That's where the pain is. That makes sense. And so that was something that I was able to use like a more subjective source and talk to my doctor. I'm not arguing about my lab results. I'm not arguing about tests. Like I'm in pain. He can't tell if I'm in pain unless I tell him. And then the next example, if you want to go to the next slide. So the other side of that is I'm just using dialysis as an example. So this is just kind of what I did. I looked at the procedure and then I ended up asking, it's like, can we get the surgeon involved just so we can see what there is to do? Then the next slide. So then on the flip side, when I was looking at choosing dialysis modalities, the sticking to the diet is very hard. Anybody who says that that isn't when you're sick hasn't had to not eat tomatoes or potatoes, and very difficult. So that was one of the things I evaluated was like how strict of a diet do I have to be, and then also the risk of infection with different modalities. And so that was a question. It wasn't something I was going to be able to Google as well and just see like, 10 to 20% of patients get X, Y, and Z infection. But that's where I would want to ask my doctor, be like, hey, this is what I've read. What's your experience as a clinician? What have you seen? Because I see myself as a patient. That's one patient. What have you seen? What prevention measures have you seen that's been helpful? Like who would you recommend this to? And so those are in my own life, my examples of how I sort through information and where I bring things to my doctor. I think that's it.
Nikki, that was really great. I was actually just sitting here listening to, first of all of your lived experiences and also your experience as a scientist. And I feel just so grateful to have you here with us today because you know what it's like to have to advocate for self, but also you've got that other side of the desk, right? Perspective of being in the research and understanding it. So I just want to say, first of all, thank you for being with us today. And then I'd love to drop through a few things. I want to reiterate a few things. One, Nikki compiled a list of resources that she had on a slide. It is on the Elevate website. So if you go to elevatechildhoodcancer.org, there is a list of reliable sources. And what I love about that is that you kind of walked through what kind of information you can get from these different things. So I noticed that, if somebody wants to look up much more like sciencey manuscript stuff, they may lean into one source. Whereas if they're looking for maybe more like clinical trials or something like that, they're going to look up a different source. Is there anything else that you want to add to that, or do you feel like that's that list of resources is pretty straightforward?
So I think it also takes a little bit of getting used to figuring out what question you're asking. Again, one of the things like I really tried to do when I got sick, because I had a lot more free time than I liked having, is really think about where something was a bit easier for me because I'm a scientist and I know how to sort through information. One of the big ones was, what question am I asking? So if you are trying to figure out just the lay of the land for a disease, that's where I would look for disease-specific resources from like a hospital, a foundation, just kind of getting a big picture. And then if you're looking for something that's treatment specific, then clinical trials. If you're trying to be like, okay, there is this gap of knowledge that I've seen from my doctors, don't know, no one knows the answer. Who's trying to look at that? That's where you want to dive into the research. Research is the place for questions. And clinical trials is a bit more what's going on, what's happening, what are we trying? And so that's how I look at it, is you have to just figure out what you're asking, what an answer would look like to you, and try and get as close to that as possible.
Yeah, I love that. I think it's so, so difficult. And so many families that are in the midst of all of this right now, a lot of times it's trying to find out like what treatments have been working, prognostic factors, things like that. I also feel like one of the examples that you walk through personally is really important. And I want to highlight that. You talked about when you were going through dialysis and get this. Please feel free to correct this if I'm wrong, but that at some point you had a symptom that wasn't common. And it looked like to me that one of the first places that you went was to Reddit. Did you go to Reddit and kind of dig around? What were you looking for when you went to Reddit? What were you hoping to learn there?
So that was just, I was like, okay, this can't just be me and I'm not doing something wrong.
Yeah.
So it was peritoneal dialysis. So if anybody's familiar with it, that's something I did myself. So I did that at home because I am, like every other scientist, a bit of a control freak. So I was worried I was doing something incorrectly. My doctor's like, oh, you shouldn't be in pain. I'm like, okay, but I am. So is it the dialysis? Is it something else? Because if it shouldn't be dialysis and no one else is experiencing it, then I'm like, okay, I got to call a different doctor. It's somewhere else to go. But yeah, Reddit was, because there's no reason for patients to get together and like lie about being in pain. I don't know people who
Right.
are impersonating dialysis patients.
Right. So you
Um,
were like looking to the community to be like,
yeah,
does anybody else have this going on? And I think I see that a lot. I've experienced it as a parent. I see that a lot on the various disease specific groups. And to me, when we're thinking about finding reliable information, that idea of looking for some confirmation, gosh, am I just crazy or is this thing going on really? Is anybody else experiencing it? I see that. But then you also really talk about how important it is to then report that finding to your physician, right? It's not like, oh, let's go out here and if somebody says to you, like, oh yeah, nobody else is experiencing this, or a ton of people are experiencing it. Our doctor told us X. So if you heard somebody say that they got on a chat group and their child or themselves they're having a symptom and they find out that other people are having it and then they find out that they've been told, oh yeah, our doctor said this. What advice would you have for that?
so so that's kind of where it's hard to be on both sides of it, because there's a lot of times where I'm like, well, physicians should just listen to their patients more. And there's sometimes that doesn't happen because doctors are overworked and you get 10 minutes with your patient. And maybe most of your patients don't feel comfortable bringing that up. You know, sometimes the doctors that are a bit more dismissive, in my experience, are also the ones that don't get as much time with the patients. So maybe they don't know and they're going based on their experience as someone who has not been sick or has not had that disease. And
Right. So
then, yeah, go ahead.
So like trying to step back in and have that conversation again with the physician and kind of kind of go from there and recognize that there's a lot of different things that they may be
Yeah,
facing as well. But it feels nice to hear from others that they're going
yeah,
through something. But generally still trying to reframe those questions back to the physician. So
yeah. And not accusing of like necessarily like it is really nice to have a community to voice frustrations, but recognizing that physicians are trying to help and being like, hey, no, this is something genuinely I'm experiencing it. Even if I'm just telling you so you know for the next patient, if the next patient experiences it,
mhm.
the second one, like my nephrologist, different nephrologist who I had for 9 years was like, hey, yeah, I had a different patient who had X, Y, and Z thing that you said happened. I just want to make sure I told the story correctly.
Yeah, that's nice. And with these diseases, a lot of times they're learning I mean, we continue to learn
Absolutely.
through all this research. So, and all these different experiences. There was another slide that you showed that I thought was just really important. And it was about how to reframe questions. And what I really loved is one of the things that you did was really try to help people reframe questions to get away from, like, if they're going to ask a direct question to their physician, right? We can ask questions of lots of things. We can have a question and we can go dig down into manuscripts and try to read the science. But we can also just try to get information directly out of our clinician. And one of the things that I thought was really good advice that you offered was trying to reframe the questions to get away from yes and no answers and into more open-ended, questions. So you had one question that was, should I try immunotherapy? And it was like, well, when is immunotherapy typically used for people with this cancer? I see people asking some of these kinds of questions out in some of the disease specific chat groups as well, and I'll see the same thing. Should I try immunotherapy? Well, the people in that group don't really know your entire unique makeup. So your physician is going to have that bigger picture. And so being able to ask the physician, hey, when is immunotherapy typically used for people with this cancer? And that way we're focusing more on the clinical evidence and appropriateness for the individual rather than, since these cancers can be pretty unique to each patient, right?
Yeah, and there is all sorts of processes. I'm trying to think of one I know for at least like blood cancers and things like that, there's like standard, like you have a score for different things and it's age, it's tumor size, it's when it was diagnosed, it's if you are anemic as well. And then if this, then this, and there's all these flow charts. And that's part of how those decisions get made. With rare tumors, it's much harder.
Mm-hmm.
And also in rare and pediatric cancers, you have patient families that are much more involved and aware of all
Mm-hmm.
the different things happening. So you do have people who immunotherapy, they know about it before their doctor mentions it.
Mm-hmm.
And so you're exactly right. It's very unique. And you're not going to get, especially if you're talking to a physician who's not your own physician, they're not going to be equipped to be able to answer a yes or no question, but they can tell you what they typically would see in big picture and what the standard is.
Right. And so mainly just understanding how can we ask a question so that we can get the information we really wanted, which I thought that
Yeah.
that chart that you created, and we're going to see if we can't make that available as well on the website, because there's a lot of really good reframing of this was the way I was typically asking the question, but this is what I really wanted the answer to. So I just wanted to say thank you. I know our time is up here today. If people have questions after that, feel free to submit them. Otherwise,